Okay, I think we're ready to begin.
Hi, everybody. This is Nicole. I am the co-director of the Surmeno Connection, and I am excited today for our webinar with the Cusp. To tell you a little bit about the Surmeno Connection, most of you are already group members, but the Surmeno Connection is a nonprofit that myself and Stacy Reeve founded in 2015. We are both Stacy and I are in surgical menopause, and we saw that there was really a need for more education and support surrounding surgical menopause, as both of us sort of struggled through our own treatment, and we decided we wanted to collect a lot of information and provide an educational resource for women who were similarly struggling, and also to provide hope and potentially to get them to the right medical resources, so that they wouldn't have to go through what both Stacy and I went through in our journey. So you guys, you're currently muted, but what's going to happen is towards the end of our webinar, we are going to open up the Q&A. So we're going to answer some questions live with two of the wonderful doctors at the Cusp, Dr. Mindy and Dr. Tammy. So I'm going to turn it over to Dr. Tammy to introduce herself and tell us a little bit more about the Cusp.
Hi, thank you so much for having us, Nicole. I'm Dr. Tammy Newhouse, and I'm the Chief Medical Officer of the Cusp. And the Cusp is an online medical clinic for women navigating menopause and perimenopause, whether it's natural or surgical or chemical. And we really have gathered the best experts in the fields of psychiatry, gynecology, dermatology. We incorporate naturopathic medicine and integrative physicians to come up with the best practices to help women manage their symptoms and also live a better life. So that's a little bit about, so we offer telemedicine video visits, and we have a bunch of resources on our website. And we're really here to support all women going through the change, however they best want to do it. It's also personal for me. I also went through surgical menopause. I'm a BRCA2 mutation carrier, and I chose preventative surgeries. And so it's also very personal for me as I had to manage my own menopause.
Yeah, absolutely. Dr. Mindy?
Hi, everyone, and I am Dr. Mindy Goldman, and I am an advisor to the Cusp, and I'm a general gynecologist and also have a specialty in management of menopause for cancer survivors. And I am really excited to be here today and help answer some of people's questions.
Great. So guys, we got so many questions when we opened it up to our group, and basically what we wanted to do was to shy away from more personalized questions and create a list of generalized questions based on what we received. So we picked about 20 questions that we're going to start with Dr. Tammy and Dr. Mindy. But just before we do, I am going to read a small disclaimer about the following, which will be the question answer section with the doctors. So the disclaimer is, what you hear today is informational only and not actual medical advice, but the Cusp can provide personalized medical advice to members that sign up with them. All right, so without further ado, we're gonna hop right in with our first question, which is going to be directed to Dr. Mindy. Dr. Mindy, what is the difference between natural menopause and surgical menopause? Why are some women in surgical menopause still, years later, experiencing bad symptoms?
Natural menopause, the definition is a year without menses, and the average age of menopause is 51. And when women go through natural menopause, many women can start noticing menopausal symptoms like hot flashes and mood disturbances and sleep disturbances before they actually hit menopause. but it
Right.
tends to be sort of this gradual entering into that phase. And so sometimes the symptoms tend to be more gradual. Surgical menopause is when someone has their ovaries removed. So oftentimes there's this confusion of, is that a hysterectomy? Hysterectomy involves removal of the uterus, but the ovaries put out the hormones that keep someone from going into menopause. And
Right.
if someone has not gone into menopause and they have their ovaries out, that puts them immediately into surgical menopause. And oftentimes the symptoms are more severe because they went from having nice, normal menstrual functioning to boom, right into menopause acutely. And we know that upwards of 90% of people experience symptoms in that first year after menopause, and that for most people, the symptoms tend to decrease with time. There's about 15% of people that even after about 3 years of being menopausal, will still notice significant enough symptoms that they often seek out treatment. And that's the same whether it is for surgical or natural menopause. For both of those, even though the symptoms may be more severe for surgical initially, with time they tend to get less for both, but there's a small percentage of people that persist in having symptoms.
Oh, okay. Wow, that's very interesting. I didn't realize that. Okay.
One
So,
thing also to note with that is if
yeah.
a woman does have a hysterectomy but keeps her ovaries, she may be at risk to go through menopause a little bit earlier. So while she won't have periods, she meets the definition of menopause, but sometimes the blood supply to the ovaries can be damaged. And she might start to have more symptoms of perimenopause and menopause, as hot flashes and night sweats, sooner than that age 51.
Right, right. Yeah, we've had a number of women in our group who've talked about just what you're explaining right now. So we're going to just move on to our second question that we have, and this question is directed at Dr. Tammy. So, Dr. Tammy, what kind of exercise is recommended for surgical menopause? We have noticed that the higher intensity exercise seems to affect HRT for the worse for a lot of our women.
So this is interesting. Mindy and I chatted quite extensively about this. Recommendations for all women and men for that matter is we recommend 2.5 hours of moderate intensity cardiovascular exercise every week. This is your key in preventing cardiovascular disease, diabetes, certain cancers. It's actually the easiest thing that you can do to start getting your life in order and getting your health in order.
Definitely.
Exercise in general shouldn't affect hormone therapy metabolism. However, if you're a patch wearer, or even with some of the creams or gels, and if you put it on too close to exercise, sweating can lift your patch off. Or if you put your cream on and then go for a swim or a jog, you may sweat your cream out before it's properly absorbed. So that's sort of, definitely something to think about is how are you taking your medication and is that affecting you?
Right. I mean, are there certain things that can be done to obviously mitigate this response? And because it is a common issue that we do here in the group is they feel like their hormones have dropped significantly after exercise. Do you have any suggestions, I guess?
The other thing that I could bring up is if you are exercising a lot and losing weight, it may be that you eventually do need more estrogen. I mean, we have a lot of estrogen in our adipose tissue, our fat tissue. We convert into estrogen. And if you've lost a lot of fat, you may start having more symptoms and you need a higher dose.
Right. That makes a lot of sense.
I just wanted to add that just to sort of reinforce what Tammy was saying, it is amazing, but there is data, for example, with breast cancer survivors, that regular exercise can decrease the risk of recurrence and improve overall survival. So if there's one thing that we're really trying to make sure that people are doing, particularly after menopause, it is regular exercise. We know that metabolism slows and regular exercise can help to maintain normal body weight, but also has so many implications when it comes to disease prevention.
So don't let your hormones stop you for exercising. Just that's really important.
Yep.
Yeah, absolutely. I think that's some great advice because we don't want women stopping exercise because they're afraid of messing with their HRT.
Yep.
Right. And there's
Um,
lots of formulations to get the estrogen in your body, whether it's rings or pills. There's lots of ways to mitigate that.
right. Okay, great. Okay, so we're going to direct this again at Dr. Tammy. What is the reason for weight gain in surgical menopause, and what can women do to help this?
So weight gain is associated with surgical menopause and frankly perimenopause and menopause and being a middle-aged person. Our metabolisms do slow as we age, and estrogen is important in our metabolism. What we really find is that it's a loss of estrogen that contributes to weight gain in your belly, which is where we tend to notice it. So maybe you had a nice hourglass figure with a chest and a bum, and then you go through menopause and suddenly you've got this big belly or spare tire, all of that. And we know that there's some actually really interesting studies about that it's probably estrogen levels falling and FSH, follicle stimulating hormone levels rising, that changes where we put our fat. And women who do go on estrogen therapy do find that it's easier to lose the fat in your belly. You're not, hormone therapy doesn't cause weight loss, but it can help with that redistribution more into like a female or an hourglass body type as opposed to the apple.
Right.
But in general, if you are going through an instant loss of estrogen, which makes you feel good, it affects your brain, it affects your joints, it affects your bones, it affects so many things, which affects how we eat and how we live our lives too.
Absolutely.
And Tammy and I have talked about this. I think if there's a time period that we could tell people, now is the time to really look at what you're eating and exercising. It's in the perimenopause, or if someone knows they're going to be put into surgical menopause, that is the time period, because for the same diet and same amount of exercise, women get frustrated because they will gain weight. And so something needs to change, either changing your level of exercise, changing what you're eating. People who didn't have to think as much about their diet now have to think about their diet, or changing both. And that persists not just in the perimenopause and with natural or with surgical menopause, but really for the rest of women's lives.
Right. Once they hit that perimenopause or menopause mark, a big shift. That makes a lot of sense. I guess, leading into the next question, it's a perfect follow-up to the last question. Dr. Tammy or Dr. Mindy, are there any dietary recommendations for surgical menopause? And are there any dietary changes that can combat hot flashes, which is a common side effect of both surgical and natural menopause that women deal with?
So there is a lot that you can with diet to both prevent disease like cardiovascular disease and diabetes and cancer. And then there's also a lot that you can do in avoiding foods that aggravate the symptoms like hot flashes and night sweats. And one thing that we found with the Cusp is we really prefer a timed eating schedule. If women move their caloric intake to the daylight hours, some people call it the 7-11 diet or intermittent fasting or 8-hour, 16-hour interval. But if you eat during the daylight, let's say in an 8-hour window, and you give your body 16-hour fast before you eat again, it really does help prevent some of these chronic conditions. The other thing that is key for people going through menopause is that having a good 3 or 4 hour window between when you finish eating or drinking at dinner and to when you're going to bed really improves your sleep. If you go to bed full, you're actively digesting food, which raises your body's temperature, and that's going to set you up for restlessness and night sweats. It's also going to have blood sugar spiked all through the night, which can disrupt your sleep. So really, truly cutting off your calories a good 3 or 4 hours before you go to bed will help tremendously in preventing night sweats. We do know that there's plenty of foods that trigger hot flashes, caffeine, alcohol, red wine, you can just throw that out the window. Sugar, simple sugars and carbs, spicy food, even hot beverages. So, you know, if you're going through the process, I really recommend keeping a journal and seeing what's causing your triggers so you know what to avoid.
Absolutely.
Yeah, not just food, even like changes in ambient temperature. It goes from being cool to really warm. That may trigger for some women. And so I think a lot of times, once women learn what their triggers are, they can adjust their diet. If they're going to be going out and it's really hot, making sure you're dressing in layers, and really kind of identifying what are the triggers so that you can control things better.
And if we're talking about schedules, the other thing, I mean, both Mindy and I avidly recommend cardiovascular exercise, high intensity exercise, but it's really important to do that exercise in the morning, well before you're going to go to bed at night, because exercise also increases your core temperature. And if you exercise at 6 o'clock at night, try to go to bed at 9, you will be hot and sweaty all night long.
Right. Yeah,
it's also better for your metabolism if you exercise in the morning. That's going to sort of kick things into gear and let your body work more efficiently through the day and burning calories.
Right. Well, yeah, I guess that goes hand in hand with good sleep hygiene, right? So that makes a lot of sense. Okay, so the next question we have, I'm going to direct towards Dr. Mindy. Are there any supplements that women in surgical menopause should be taking to prevent long-term health issues from the result of the surgery?
Sure. So the big things that we worry about in terms of health risks are cardiovascular and bone health. So we know that the number one cause of death for both men and women is heart disease, and the risk is much higher in men than women until menopause. And then it starts going up in women, and at about in the early 60s, it's equal between the two. And we know that the estrogen that is produced from the ovaries helps protect against heart disease. So that's why we've been talking a lot about exercise. There's, in terms of heart disease, not so much from supplements, but there are modifiable and non-modifiable risk factors for heart disease. The non-modifiable is you can't change if you have a family history of heart disease, but the modifiable ones are making sure your weight is okay, that you don't smoke, your blood pressure is okay, your cholesterol is okay, so that does come into people's diet, and hopefully that people don't have diabetes. Those are all risk factors for heart disease, and explain why exercise and eating a healthy diet, more fruits, vegetables, whole grains, is really important in trying to mitigate cardiovascular disease. The other big one is bone loss. So women actually reach peak bone density at age about 30 to 35. Everyone has a loss after that, but the major rate of loss of about 2 to 3% per year is right after menopause. So people who are thrown into surgical menopause are going to immediately have that increased rate of bone loss. And we know that both estrogen is helpful for maintaining bone density, and that's one of the benefits of people who do go on to menopausal hormone therapy, but we also know that calcium supplementation is important for bone health. Guidelines have changed a lot. We used to tell people 1,500 milligrams a day of calcium supplementation after menopause. Before menopause, people don't have to take extra calcium. They can usually get enough from their diet. But after menopause, that it's hard to get enough from dietary sources alone. We now know that actually too much calcium can have negative cardiac effects. And so guidelines have shifted to not having quite so much and taking no more than 1,000 milligrams a day of calcium supplementation, whether that's from dietary sources or usually needing 1 or 2 supplements a day. Most of the supplements over the counter are 500 or 600 milligrams. If someone has enough calcium in their diet, we'll tell them to take 1 supplement a day with vitamin D, which helps with absorption. Usually that's in the vitamin D, that's about 400 international units. Sometimes if people's D levels are low, they may need more than that. So the main supplement we start talking to people about is calcium. If people aren't eating a well-balanced diet, taking a multivitamin can oftentimes be beneficial just for maintaining health.
Absolutely. Okay, thank you. Okay, so moving on, we're going to talk about something that's very much connected to the supplements and something Dr. Mindy was just talking about. I'm going to direct this to you again, once again, Dr. Mindy. How often should bone density scans or mammograms be performed once you are put into surgical menopause? We have a lot of women in our group who are below the age of 40, so.
Yep. So let's talk about the bone density one first, because I think that's a little bit more straightforward. So as I mentioned, we know that the major rate of loss in terms of bone health is immediately after menopause, but guidelines for bone density say women should start regular bone density screening at 65 or sooner than that if they have risk factors. So one of the risk factors is earlier menopause, but whether we get a bone density early oftentimes depends on if they have other risk factors too, like smoking, like a sedentary lifestyle, if they have been on steroids. We know that long-term steroid use can have effects on bone health. So oftentimes women may get a baseline bone density at some point after they become surgical menopause. There's no strict guidelines that say it needs to be 6 months or a year or 2 years, but oftentimes a baseline, and then they don't necessarily need ongoing unless they have more loss than expected. But whether you get it or not oftentimes depends on other risks besides just surgical menopause. In terms of mammograms, it's a little bit more controversial because some of the difficulties are that the large guiding organizations in this country often differ in terms of when their recommendations are to start mammograms and how often to get them. Meaning American Cancer Society is different than North American Menopause Society, American College of OBGYN, and the U.S. Preventive Service Task Force. They all say that there should be what's called shared decision-making, which is looking at what someone's risk factors are for breast cancer. So we know that, that when women go through later menopause, so more estrogen being produced, that can be a risk factor for breast cancer, but that is a subtle risk. The big risks for breast cancer are having a prior family history or prior biopsies that showed atypical change, certainly people that have genetic mutations. And so when it comes time, most people will say, the large guiding organizations either say 40 to 45, or U.S. Preventive Service Task Force says in low-risk women, they can get their first mammogram at 50. Once you get them, they are between 1 to 2 years. If you look at a population basis, changing people to every 2 years does not change overall mortality from breast cancer and decreases the number of people that are called back for false positives. But again, you need to individualize. If you have a family history, you should be getting it at least 10 years before the onset of the disease and a first-degree relative like your mom or your sister, and usually it's an annual mammogram then. So just surgical menopause alone, I would say you need to take that into context with someone else's risk factors as well. And Tammy, I don't know if you want to add to that.
I just want to break in here 1 second. Sorry, it's Valerie. Could you guys also address if you should still get a pap smear with no cervix?
Tammy, do you want to?
I wanted to say, just to comment on if you are a BRCA1 or 2 mutation or another breast cancer mutation, then screening usually starts at age 25. You usually get a baseline MRI at 25, and it's annual following that if you do not choose to have preventative surgeries.
Yeah, what I was mentioning is for low to average risk women. There are national guidelines out there for how to follow people with genetic mutations like BRCA, and that is very, very different than for the general population. In terms of the question about pap smear screening, if someone has surgical menopause and has their ovaries removed, but still has a uterus, they need to have the exact same screening for cervical cancer, which guidelines now say you begin screening at age 21. Screening is every 3 years for PAPs. If you do HPV testing, it can be every 5 years. But most gynecologists will recommend every 3-year PAP screening up until age 65. If someone's PAPs have been normal within the past 20 years, at age 65, we stop screening. If someone has had a hysterectomy and their cervix was removed, they don't need to have pap smears unless they had had high-grade cervical dysplasia. Then we typically will continue screening the upper part of the vaginal cuff. And if their paps have been normal, there is no reason to have pap smears after hysterectomy.
That's right.
Okay, great. Okay, so we're going to move on to a question for Dr. Tammy. Dr. Tammy, how much can surgical menopause and hormones affect one's mental health?
Well, we do know that for anybody entering perimenopause or menopause, that there is a much higher, if you have a history of mental health disease, you have a much higher risk of having an aggravation of that in this time. When you're going through perimenopause and menopause, naturally, the fluctuations in hormones, they can wreak havoc on your mood, and mood swings and irritability are very commonly tied to their PMS and even at baseline. And absolutely, if you go through surgical menopause, but instantaneous removal of your estrogen, it can also aggravate your mental health history. And we know that mood swings and irritability and that rage and such quick to temper, to yell at your kids, to yell at your partner, that is one of the biggest hallmarks of perimenopause and menopause that people ignore, and they just think that there's something wrong with them. But absolutely, it is tied to your hormones. And there's a lot of things to do, whether it's through hormone replacement or through antidepressants, or even some great supplements can all help balance these symptoms that we see very commonly in menopause.
A couple of things I was just going to add. In addition to those things, we, through the Cusp, also have some great recommendations about mindfulness and things that can really help people during this time with their mood changes. But one of the questions I get asked a lot is, people think that menopause, whether it's natural or surgical, causes depression. And it doesn't cause it, but if you are inherently susceptible to that, a time period in your life where you're more apt to see it happen is with menopause. But it's not that menopause itself causes depression.
Interesting, very interesting. Yeah, we have a lot of women who struggle with mental health post-op. So yeah, so that's very.
And Nicole, when you're forced to go through surgical menopause, there's so much that goes along with that. Is it, because you have a mutation, you're at risk? Is it because you've been suffering from chronic pain or endometriosis? Is it because there's an endometrial cancer? Like, all of those chronic diseases also increase your risk for depression. And so then you add in a rapid hormonal withdrawal, and you are sort of set up for all this. So I would recommend, beyond the things that you can do through yoga and meditation and mindfulness and supplements, having a counselor and a therapist, people that you can talk to, it helps so much. Like, situational, even being stuck in your home, like that's the beauty of telemedicine, is you can talk to somebody, because it really is important to connect and have an outlet for the feelings.
Yes, that makes sense. As the child of 2 psychologists, I will highly recommend some talk therapy.
It's coaching. It's everybody can benefit from it.
Okay, so we're going to move on to another question for Dr. Tammy. Okay, we know that thyroid and sex hormones are closely related and affect one another. What advice would you give for those struggling with both thyroid and obviously loss of the ovaries?
So we do see women are in general at higher risk for thyroid disease than men. And a lot of that can manifest in midlife or even sooner as well. And sometimes thyroid disease is autoimmune, and other autoimmune disorders can play a role in other things that may lead to a hysterectomy. So there is a lot of overlap between the two, both thyroid hormone and estrogen. They're so important for the functioning of our metabolism and most of this, our hair, our skin, our nails, our digestion. So there is a lot of overlap between the two. Oral estrogen can alter thyroid medication metabolism. So it is important if you're starting oral estrogen, you want to make sure that you're getting your thyroid tested frequently to make sure that you're on the proper dosing of your Synthroid or levoxythyroid or whatever you're taking. So that is important. Sometimes doing a transdermal estrogen may leave things a little bit more even for you.
Interesting. I didn't know that. That's very important to know for women on oral estrogen. Right. So we're going to move on to another question. This one is going to be directed to Dr. Mindy. Dr. Mindy, what happens to endometriosis during surgical menopause? And why do some women struggle with their recurrence?
So first of all, with endometriosis, there's still a lot of controversy over what exactly causes it. The best knowledge, or our best working knowledge, is that the endometrium, or the cells that line the lining of the uterus, that is called the endometrium, rather than flushing out when someone has their period, it backflows through the tubes and implants within the pelvis. And just like when the ovaries produce the hormones that stimulate the shedding, the inflammation and shedding of the lining of the uterus with the cycle, they can stimulate those other implants that are in the pelvis associated with a lot of pain. There's a lot of things about endometriosis that we don't know. People can have, at the time of surgery, we'll do these laparoscopy and find people have lots and lots of endometriosis, and that doesn't always correlate with the degree of pain. So you can see lots of endometriosis and little pain, and you can see little endometriosis and a lot of pain. So there's a lot of things that we don't know about endometriosis. That being said, we know that endometriosis is stimulated by the hormones that are produced during the menstrual cycle. So with surgical menopause, that is a treatment for endometriosis. Right. So typically what we expect is that if your pain was cyclic and if your pain was due to the hormones that are produced in the menstrual cycle, with surgical menopause, endometriosis pain should get better. For people that it doesn't get better, we know that endometriosis can cause other things like scarring, and pelvic scarring can oftentimes be a cause of pain. So I'll tell people it's not so much that they have active endometriosis, but it may be the scarring that was a result of the endometriosis that persists in causing pain. One question that a lot of people will ask is, what about if I take hormone therapy? Will that stimulate then the endometriosis implants again? And the doses of hormones in menopausal hormone therapy is so much less than what our own bodies produce when we're menstruating that we don't think, there isn't good data that says that hormones really cause stimulation of endometriosis. So that's not a contraindication for someone to taking menopausal hormone therapy.
Okay, wow. Dr. Tammy, is there anything you wanted to add, or should I move on to the next question? You're good. Okay.
Nailed it.
All right, Mindy, you cover that. Okay, so the next thing we're going to ask about is a very common question. It's a pretty sensitive question that we get oftentimes in the group, and it's something that I personally wasn't prepared for. Nobody talked to me about it prior to my ovary removal. But how can low libido and painful sex be treated? Are there any alternatives to hormonal options to boost the sex drive? And I'm going to direct this to Dr. Mindy, but Dr. Tammy, feel free to chime in.
So first of all, women's sexual functioning is becoming an area within gynecology that is actually finally having good studies that are being done.
Yay.
And we know, I know, which, right? It's like, it's really important. And this hadn't, for years, we didn't have good quality studies being done. And some of the things that are difficult, though, when looking at that is we know that for men, sexual functioning is much more physiologically based, and for women is much more psychologically based.
Right.
So there's lots of things that play into how we feel sexually. Medications we're on, our mood, whatever else is going on in our lives, the status of your relationship with your partner, hormones, your hormonal functioning, and vaginal dryness. And so it's more difficult, I think, for women than it is for men when you're addressing libido issues. And one of the things that's really important is to separate out libido from painful sex. Because in these good quality studies that are now finally starting to be done, they all say, if you have a dry vagina, and if it hurts to be touched or have penetration, it's typically going to set something up of who wants to do something that's painful. So it sets up this self-protective mechanism. So any of the studies that are looking at female sexual functioning say you need to treat the dryness first. And there are many ways that you can treat the dryness, whether that's with over-the-counter things or local hormones. So local hormones, vaginal hormones, are very different than systemic hormones that get into your bloodstream and help to treat things like hot flashes and night sweats. Local hormones are targeted directly towards the tissue, towards the vaginal tissue. There's very little absorption, if any, into the bloodstream. And so they can be used even in people who have contraindications to taking systemic hormones. If you adequately treat that, so that's whether over-the-counter things, local hormones, a lot of people will ask about devices. There's lasers and energy devices. Not a lot of data yet establishing safety and effectiveness of that. But if you treat that, then you look at libido separately. And if sex drive is still an issue, there are, again, addressing it from a holistic fashion of all those things that I talked about. There are some medications that sometimes people will give to affect libido. One is, interestingly, one of the antidepressants called Wellbutrin may help to improve libido for some people.
Oh, wow.
Other antidepressants can actually depress libido, but Wellbutrin is one that may actually increase it. Giving women testosterone. It is not FDA approved for women, but it can be made up into low doses where you don't get male hormones, side effects like acne or hair growth or oily skin. And that can be made up into creams and abdominal rubs and vaginal creams, and that may help out. There are a couple drugs that are actually on the market specifically designed for libido. They've been shown in randomized controlled trials to mildly improve libido. One is flibanserin, and the other one is, how do you pronounce it, Tammy? Vicelli? I think. I always forget how to pronounce it. And they may have mild increases in overall sexual satisfying events on a month. They're not perfect. One has to be taken every day, can't be used with alcohol, the flibanserin. The other one is an injection that people take 45 minutes prior to anticipated intercourse. Those are, I think, a step in the right direction of finally getting some medications directed specifically for women. We know for some women, hormone replacement therapy, menopausal hormone therapy will help out. So I think it's really making sure there's a lot of times people don't talk to their doctors about this. It's important for us as physicians to ask patients about their sexual functioning. And we also encourage our patients really talk to us. And if you're having problems, let us kind of look at it as a whole and see what are the issues that should be addressed.
I have just a couple of things to add to what Mindy said, is that one, even if you're taking hormone therapy and your doctor has put you on it and you feel okay, it may not be enough to combat vaginal dryness or bladder issues. the genitourinary syndrome of menopause. That's when the mucosa, which is the lining of your vulva, which is the outside, and the vagina, which is the inside, and the bladder, by the time that that systemic hormone therapy gets to those tissues, it's oftentimes not enough. And one of the biggest mistakes I've seen is women not adding local estrogen to their vulva and their vagina. So that's really important. And as Mindy said, there are little to no contraindications. Even breast cancer survivors can safely use vaginal estrogen, and they can really increase the quality of your lubrication. It brings back collagen and elasticity, and it sort of, you know, brings that whole tissue back to life. I even saw this in myself, in my sister. Both of us went through surgical menopause, and we went on our hormone therapy, and you know, my sister kept having recurrent, what she thought were yeast infections. She saw 3 different gynecologists in my former practice, and nobody gave her estrogen. And she finally told me about it. They said, you need estrogen. And sure enough, within 2 days, she was feeling better. So that is like my biggest message is you can do that. Vaginal estrogen is key. A couple other things is, you know, when we talk about low libido, and Mindy nailed it. Like women are complicated. Men have an on and off button, and we need to have all circuits firing. And if our partner pissed us off that morning, guess what? We're not having sex that night, right? Like there's like a 24-hour reset when everything has to be right. And I don't like it when women talk about their low libido, and it, truly, libido is personal. Everybody has their own libido. Both women and men, libido do fall as you age, but generally women fall faster than men. The problems arise when there's a mismatch in a relationship, or when it is bothersome to yourself. So it's a very important conversation to have with your partner, is looking at what is missing. Is it intimacy? Is it actual sex? Because these are important conversations to have. And then enough treatment that I'm a very, very big fan of, besides the medications and the vaginal estrogen and whatnot, is actually like prescribed orgasms. I think that if you were looking for a challenge for yourself, you should have an orgasm 3 times a week, whether you're responsible for it or your partner is. But the more you have, it fires chemistry in your brain, and the more it's exciting and you become interested, and it's a wonderful self-propagating habit. So buy whatever you need to buy. There's great vibrators out there. There's new devices. There's new toys to help with stimulation, and enjoy your body. It's a great way to bring things back to life.
And I'm going to add just 2 things. One is there actually is no data on what is normal sexual functioning as we age. And so that's one of the problems, that we know that libido tends to decrease, but there's no data on what's normal. And many people who are comparing their sexual functioning to what it was in their 20s, where for most people it was much, much higher. What matters is if it's a problem for you, or if it's a problem for you in the context of a relationship. So that's one thing I wanted to add. And the other is just with breast cancer patients, in terms of local vaginal estrogen, it comes in 3 different ways: a cream, a ring, and a suppository. There is some concern with the cream formulation, even though the data is not that good. There's some concern that if you push a whole bunch of cream into the vagina, that there's a greater surface area and the potential for absorption into the bloodstream. So we tend to avoid the creams unless we're rubbing it into a very specific area. We tend to avoid the creams in breast cancer patients. The rings and the suppositories, totally fine.
Right. Okay, great. You guys really covered that one very thoroughly. I appreciate that.
We like to talk about sex.
Yes.
This is a common issue.
Hey, Nicole and Tammy and Mindy, I just want to do a quick time check. We've got about 14 minutes left. We have a ton of questions on the Q&A as well, but I want to get through the typed in questions. I just want to bust in here and say to everybody on the Q&A, we've got lots of great questions there. We will get to your questions. We just might not get to them in today's session. And Mindy, thank you, by the way, for addressing surgical menopause because of cancer. So with each answer going forward, could we make sure that we sort of address that for women that were put into surgical menopause because of cancer that aren't allowed to take hormones? They want to hear a little bit of that perspective too. And Mindy and Tammy, you guys have been doing a great job of that. Just want to make sure we continue on that path moving forward. Thanks. Sorry to break in.
All right, do you guys want to answer that? One of you?
I think the question was about treatment of menopausal symptoms in people who are made surgically menopausal but have contraindications to taking hormones. So specifically people like breast cancer patients who can't or shouldn't take hormones, endometrial cancer patients can't or shouldn't take hormones, although the truth is there's no data that says that estrogen will affect overall survival in early stage endometrial cancer. But in those patients, there are plenty of alternatives to hormones that can treat menopausal symptoms. One of the things we offer at the Cusp is we have integrative providers and naturopaths that help us out with non-hormonal options, things that include things like maca and black cohosh and different herbal products. There are actually specific prescription alternatives that can also help out with hot flashes and night sweats. Low doses of some of the antidepressants, neuropathic pain relievers, anti-seizure medicines, a blood pressure medicine have all been shown to help out with hot flashes. Now, the interesting thing is, why would all these diverse drugs help out with hot flashes? One is we don't exactly know what causes a hot flash. One of the theories is that there may be some temperature regulation zone in the brain, and that any drug that works centrally in the brain may modify hot flashes. Also, calcium inflow and efflow out of cells may affect temperature regulation, and many of these drugs affect calcium inflow and efflow. The most fascinating things is in all of these drugs, the doses that are used are much lower than what the drug is intended for. So in these antidepressants, for example, the doses that are recommended for hot flashes are not typically going to be able to treat if someone has a major depressive episode. These are much, much lower doses. The thing that I try to tell my breast cancer patients is nothing is as effective as estrogen, but you do not have to feel like I just have to suffer. There are many, many things that we can offer, both on the integrative side as well as prescription alternatives to hormones.
Right, right.
And remember, a lot of the things that we talked about for weight loss actually help with symptoms of menopause, hot flashes and night sweats. Timed eating during the day, protecting your sleep. So low glycemic foods, all of these really help with the, there are so many symptoms of menopause. The worst oftentimes are the hot flashes and the night sweats being disruptive to the quality of life. But eating and exercise and sleep can get you very, very far. And the medications that Mindy described work wonderfully. Gabapentin is a chronic nerve pain anti-seizure medication that is used in very high doses for neuropathic pain and for seizures and for all kinds of things. And we use it very low doses, and it can be as effective as estrogen in eliminating night sweats. And it works really well, and there's very, very few side effects to it, and there's no risk to it. It can't cause cancer. So
it also can cause sedation. So it's a great one if people are having their hot flashes or night sweats. If they're having their hot flashes at night and it's disrupting their sleep, gabapentin is a great option.
That's great to know that one. Yeah, absolutely. Yeah, we have a lot of women in our group who can't take HRT due to cancer diagnosis or cancer history. So I think at this time we're gonna jump into the Q&A and answer some of your questions. Again, guys, we wish we could answer a ton of questions, but we're on a time limit. So so let's talk about. So I'm going to just address you guys by the first name. I'm going to start with this first question here from Karen. Karen asks, how do you guys feel about vaginal rejuvenation and for vaginal health? Many of us have had great results. And again, I think we covered a little bit of this already, but I think this is in reference to treatments like the Mona Lisa touch, which I've actually had. And I think there are other laser treatments that are similar. So
I have seen great results with the energy devices for vaginal rejuvenation. I hate that word because I don't think a vagina needs to be rejuvenated. A vagina is beautiful and wonderful in and of itself, and we just for it. My husband is a dermatologist and he's a laser specialist. And so what they've done is they've taken laser technology that we've used on the face, so fractionated lasers, which basically makes little teeny tiny holes everywhere. And
Right.
when your body heals, it brings in more collagen and elasticity and improves tone. And so they've made a little wand, looks like a dildo, that does the same thing inside the vagina. And it works. It makes lots of little tiny holes, and when your body heals it, it improves collagen and elasticity. So I actually have seen great results with it. The problems with it is that it's very expensive and it's unregulated. It has not been approved by the FDA yet due to lack of studies, and also some potential to cause burns and scarring and poor outcomes. Right. So I think that while it is still being investigated, I'm very hopeful. There's a lot of devices that are coming out for home use that aren't necessarily activated laser, but there's radio frequency, there's cooling, there's a lot of things that are coming out. I think that, going to a provider who is a gynecologist, I would never go to a dermatologist to have my vagina lasered. I just wouldn't,
No kidding,
So, because they don't understand a vagina. You need to go to somebody who understands what it should look like, what it should not look like.
Right.
And right now we proceed with caution because it's not thoroughly regulated and FDA approved for use down there just yet. Mindy,
and I'll add just a couple things. So, most of the energy devices that are out there are based on the first data came out with regarding the Mona Lisa. So the Mona Lisa was actually FDA approved in 2014 for skin resurfacing, and it was being used off-label for vaginal dryness. And some of the problems in terms of the studies is there's a bunch of studies that are out there, but they're looking at it for different things. Vaginal dryness, the so-called vaginal rejuvenation or tightening, urinary incontinence, pelvic prolapse. And so the studies have different endpoints. Also, in medicine, for us to be able to tell if something is effective, you want to do these randomized controlled trials. And it's hard to do a sham device to do these randomized controlled trials, and very few of the studies have had a sham controlled device. So we have a lot of little studies. They look pretty good. And they're looking at different endpoints. The FDA put out that warning statement about burns, but most of the studies actually haven't shown burns. What I have told people is that if money isn't an issue, this isn't FDA approved, it's about $3,000 out of pocket for 3 treatments over the course of a year. We have limited data, but what data we have looks pretty good, that I'm willing to provide recommendations of places that do it. For women who have breast cancer, who are on aromatase inhibitors that work by shutting down all estrogen production in the body, there's some suggestion that they need even more than the typical 3 treatments in a year to have it be effective. Right. So I sort of agree with Tammy that I feel like, if you're going to have it done, it should be done by a gynecologist. I think it would be nice to see this get better quality studies to get FDA approved, so that we can really tell people about safety and effectiveness. But I think it's important that we have lots of options for women, right? That aren't just over-the-counter lubes and moisturizers and hormones. I like that we're actually finally starting to study something like this, because I think it holds a lot of potential.
That's great. Yeah, I totally agree. Okay, so we're going to move on to another question. All right, this one is it's an anonymous question, and this is actually a question we often get in our group. Basically, do you guys recommend progesterone if they don't have a uterus? Women who have had their uterus removed and don't need to take progesterone to prevent uterine cancer, essentially.
No, you do not need to take progesterone. In fact, the recommendation is not to take it. In the study, the WHI study from nearly 20 years ago, the increased risk of breast cancer was in the group of women who took both estrogen and progestogens. And so the group that took estrogen only had a lower risk of breast cancer. So there is no reason to take progestin if you do not have a uterus.
If you do not have.
Yeah, and you know, the interesting thing about that study is that's sort of the gold standard, and how we talk to women about hormones is based on that study. Huge trial, and there's been health updates every 5 years. And just this past December, there was a presentation looking at breast cancer rates in the participants from the Women's Health Initiative, and it really confirmed what Tammy said, that it is the progestin component that has more negative effects on the breast, and that estrogen alone is safer than we thought. One other thing, though, is that the type of progesterone that they studied in the Women's Health Initiative is different than the types of progesterones that most people are using now, which are the natural progesterones, prometrium or natural progesterone. And there's some thought that those may have less effects on the breast, but there haven't been any good randomized controlled trials that have compared those specific progesterones to the ones studied in the Women's Health Initiative. So bottom line is, when you're looking at menopausal hormone therapy, the progestin component is the component that probably has more negative effects on the breast. And if the only reason to take it is really to protect the uterus from uterine cancer.
So just to add to this is something that Mindy and I talk about frequently. You know, if you are a BRCA2 carrier or a BRCA1 carrier, and you choose a prophylactic salpingo oophorectomy, removal of your tubes and ovaries to decrease your risk of ovarian cancer, it is an opportunity to talk about whether or not you should remove your uterus at the time of surgery. A lot of gynecologists and oncologists don't talk about that, and they'll just recommend having your ovaries and tubes removed, but then you do have to take both estrogen and progesterone to protect that uterus that is sitting there not doing anything. The risk of removing the uterus, or the reason why some doctors will recommend you leaving it inside, is to prevent the possibility of prolapse, when the top of the vagina or the bladder or the rectum can sag into the vagina. So you do need to sort of weigh the risks and benefits of what you would do in that case. Personally, I took it all out. I've already had my babies, and I chose to remove everything at the risk, because I only wanted to take estrogen. So it is, you need to be informed about this before you choose your surgery, because I've seen a number of women who've had regrets about not having their uterus removed at the time of their surgery. And then Mindy, go ahead. But
I was just going to say, the other thing that we do talk about, there is studies showing a higher risk of urinary incontinence for women who have hysterectomy. So you definitely need to weigh the risks and balance. But for BRCA carriers who, let's say there are a number that don't choose to have prophylactic mastectomies, so still have their breasts, but have their ovaries out, they may want to consider removing their uterus so that they don't have to take progestin. I think you need to individualize it and really talk. If someone's got prolapse, we know that one of the risk factors for prolapse is if you have a hysterectomy for prolapse, that's a risk factor for getting recurrent prolapse after your hysterectomy. So you need to definitely individualize, but I agree with Tammy that it's a discussion you want to have before just signing up and saying, okay, I'm going in to have my tubes and ovaries out.
And in the same vein, that
sorry, we're at time now, and I'm just so worried because we've got so many other questions here that are great. And I know Tammy and Mindy, we only had an hour with you, but And everybody with the questions online, we will answer them and submit them back to Stacy and Nicole so that they can post them to your Surmeno Connection community.
Absolutely. Yes.
Yeah, for sure. But I'll kick it back to you, Nicole, to wrap it up, and then you could kick it back to me for the end.
Sure, absolutely. Well, guys, it was a real pleasure to have you both, Dr. Tammy and Dr. Mindy. This was so wonderful. You really covered so much of the questions we get really regularly in the group. We hope to have another webinar with the Cusp going forward, maybe on a particular topic, because obviously there were so many questions that came in, and like Valerie mentioned, we're going to follow up in our group and answer a lot of them. And some of the questions I know the Cusp wanted to answer on their website and their social media and cover some of that. So you can follow the Cusp on their social media and their Facebook page. So what we're also going to do today, ladies, is Valerie has a special offer for any of you guys who are interested, who are based in New York or California, where the Cusp is currently licensed to work, and are interested in working with them and getting some great medical help and advice if you guys are struggling. So Valerie is going to put up a slide with that special offer. But thank you, doctors, today, and this was a real pleasure.
Yeah,
Thank you for having us.
Yeah, thanks for having us. It was great.
Thank you, Nicole. And I think Lauren's going to put the slide up, but Nicole and Stacy and Mindy and Tammy, thank you so much. We really have enjoyed working with you guys, and we hope that this information was helpful, and that we're going to help all of you get the care that you really deserve. As Nicole said, we want to do more of these, which is great. And Stacy and I have been privately chatting in the background saying, we got to do another one. There's so many great questions. But for those of you that are interested, you can get more details about the Cusp. And we really do have specialized, personalized care packages just for people who are going through surgical menopause. So we have a special URL here, which you'll see, meetthecusp.com/Surmeno. To thank you for attending this event. If you click on that URL, code will follow you throughout your journey on our site, and $51 will be automatically applied at checkout off our 3-month surgical menopause care plan, which gets you video visits with the clinicians that Dr. Tammy has pulled together, that Dr. Tammy and Mindy have pulled together, plus unlimited chat messaging with our team, and just a really great personalized care plan. So please be sure to check that out. Yes, we're only in California and New York, but we hope to be in more states soon, and also more countries. But that doesn't mean we're going to abandon you. So we will answer your questions and work closely with Nicole and Stacy on making sure that your questions are answered and put up in the Surmeno Connection community. But thank you so much to everybody for attending today. Thank you.